The introduction short this time. So we are also very excited to have Dr. Chris McDougal, who is an international renowned expert in neurobiology and neuropsychopharmacological treatment of neurodevelopmental disorders like autism spectrum disorder and intellectual disability. As you know, in his accomplished career, he has published over 700 publications related to this topic. He has received numerous awards and grants, and also he has extensive experience in clinical trials with this population. So he's currently the director of the Lurie Center for Autism at the Massachusetts General Hospital, and the Nancy Lurie Marks Professor of Autism in Harvard Medical School. So without delay, I think I will just welcome Chris once again. It's over to you, Chris.
Thanks again for the introduction. And you might ask, well, how is this going to be similar or different to the first talk? It's going to be more evidence-based, I guess you could say, to support the clinical approaches I discussed this morning. So in some ways it's a little more formal, I guess. But I'll probably say some things I didn't say this morning without any real intention that just come out that might be useful clinically. So let's give it a try. So I still don't have any conflicts of interest. None have arisen since this morning. I will say this, I'm not one big on self-promotion, but just a moment ago a gentleman came up to me and he held a book out and he said, "Is this you?" And it was edited by me. And I said, "Wow, I didn't know that book was out yet. I didn't even know it was released yet." So apparently there's a book out there that I edited. And he asked me if it was any good, and I said, well, it was a lot of work. I know that. It was a lot of work. But anyway, that's all I know. I have no idea what it costs or anything. That's all the truth. So, wow, anyway. It's funny, kind of interesting. Off-label. Every drug we use in autism is you're using it just because you think it might be helpful based on experience, other than risperidone and aripiprazole for irritability in children and adolescents with ASD that are FDA-approved medications. I have the same pictures that I had this morning. So it's kind of unusual to give two talks in a symposium. So I had to, they wanted me to make them a little bit different but on the same topic. So I did, but the pictures happened to remain the same. If I had a little more time, I would change them a bit. I used to show slides of the place where I lived, but then I got wiser and I said, they don't care about that. They care about where they live. So I'm going to show pictures that the audience can relate to, and that works a lot better. There's a funny story, though. Once I was going to I gave a talk in Rotterdam, right? And I was in a hurry, and I said to my secretary, just get a bunch of pictures of Rotterdam and spread them around in there. And when I showed them, they were these famous buildings and things, but I had no idea what they were what they were. So I would show it and then ask the audience to describe what I was showing. But that's just a true story, too. Now maybe you can see why I like Neil Young, because he says crazy things like I do, or vice versa. So learning objectives, understand the symptom clusters that might respond to drugs, talk a bit about the controlled studies that provide evidence for the use of those drugs, and talk about the side effects that might emerge. I showed this slide this morning. I won't cover it in as much detail, but now there are no subtypes of ASD. Essentially, there's only one diagnosis, autism spectrum disorder, so I'm not going to say anything more about that. Target symptom domains. So we're going to start with motor hyperactivity, inattention, and impulsivity, and I'm going to show you the studies and the results in that symptom area. We're going to start with stimulants. So this is the largest placebo-controlled study of a stimulant in ASD. And you learn a few things over time. The first was, so in the old days we would just say, we want to study adults with autism and we want to use a drug. So let's recruit adults with autism and use this drug versus placebo and see what happens. We didn't select the subjects based on a prominent symptom. You know, we didn't know any better. As you go on, what you have to do is say, I want to study this symptom. And all the subjects have to meet a severity threshold in order to get into the study. And they're still going to have other symptoms, right? It's still messy, but they're going to have a lot of that symptom. So this was one of the first studies to look at ADHD symptoms in kids with ASD, Asperger's, PDD, NOS, and autistic disorder. And clinically, we know most of us involved in the multi-site study do clinical work as well. We had a sense that stimulants can work really well for some people with ASD, but they can cause a lot of side effects for quite a few. So is there a subgroup that does well? And clinically, we thought that the younger you are, the poorer you do with a stimulant. The more intellectually impaired you are, the poorer you do with a stimulant. The more irritable and aggressive you are, the poorer you're going to do. Those were clinical thoughts going in. And so we said some kids are going to respond poorly. They're going to get worse after a couple doses. Well, you don't want to get them involved in a big study. You want to sort of screen them out initially. So we did a 7-day, 1-week period of time where each subject received 3 different doses of methylphenidate and placebo in a randomized way, just to see if they could tolerate it, and where everyone was blind. And if they couldn't tolerate at least 2 doses of methylphenidate, then they didn't enter the study. So then, if you tolerated at least 2 doses, you entered this formal study, which was 4 weeks long. And each week was a dose of methylphenidate or placebo in randomized order. So about 10% of the subjects couldn't tolerate at least 2 doses of methylphenidate. And what happened to them? They became irritable, big time. One dose, and they're out. 16 of the remaining subjects could only tolerate 2 doses of methylphenidate. They couldn't tolerate the highest dose. So we let them into the study, and then they would have had 2 weeks of the highest dose, the middle dose, if you will, in a randomized way. And you wouldn't be seeing this if these were sort of, quote, neurotypical kids with ADHD. The tolerability would be much better. So 58 out of 66 subjects completed the 4-week crossover phase. 7 additional subjects dropped out due to irritability in that phase. And when you look at the effect of the drug versus placebo, it was better than placebo on a rating scale rated by both parents and teachers. So it was better than placebo. What does that mean? Is that clinically meaningful? This is something else I learned over time is if you're using a medicine to treat hyperactivity and you select your subjects based on that, you're still curious to see what the drug does in other areas, right? You want to know. That's how you figure things out and learn things. So we wanted to see what it would also do for social withdrawal, for repetitive behavior, for speech problems, and for aggression. Well, social withdrawal got worse at the highest dose of methylphenidate. Well, that's not a good thing if you're treating ASD. So it can cause a withdrawal or sort of depressive-like state. And it was no different from placebo for irritability or repetitive behavior. You would think it would make irritability worse based on what I've said, but we screened all those kids out, you see, so you ensured that you'd have less of that. You enrolled kids that could tolerate the drug. The other thing that's important to know about stimulants is that they can increase brain dopamine function, right? So I talked a bit about dopamine earlier. That's the reward chemical. So if the Blue Jays win the World Series, dopamine is making you feel good. If you, I guess they have some gambling here, I don't know. If you win the lottery or something, it's probably dopamine. If you snort cocaine, I've never tried it in my life, I'd tell you if I did, that's dopamine. So whatever that feeling is dopamine. Well, stimulants increase dopamine, but they not only increase reward and your ability to focus, but they increase motor movements, right? So that's tics. What's the most effective treatment for a tic? A dopamine blocker, the most effective. So if these drugs are driving dopamine, you could think they might make repetitive behavior of autism worse, and in fact they can. They can make rituals worse. They can bring out tics, as we know. But in this study, we didn't see a difference from placebo in abnormal involuntary motor movements. So if you look at the rate of response to something, right, you could respond to different doses of methylphenidate or placebo. 44 subjects out of the original 72 responded to something. And in 9 cases, they responded to the week of placebo. So that's a fairly high rate of placebo response, considering that stimulants have such a robust hit, you know. And when we looked at, you know, were there clinical predictors of response that we kind of went in thinking, older age, higher IQ, there was nothing that was statistically significant, but there was a trend for diagnosis. And the guys with Asperger's disorder or PDD-NOS did better than those with autistic disorder, which kind of goes along the idea of the higher cognitive functioning does better on a stimulant. The way I think of it is they're closer to normal. Those guys their brain is closer to normal than a guy down here. So the closer your brain is to neurotypical ADHD, the higher your likelihood is of responding to a drug that works in ADHD. And I think that's true. And this shows you that data in another way. There were a lot more kids in the study with autism, 47, versus combined Asperger's or NOS of 19. But if you look at the number and percent of response for the top line, it's no different between any of the doses of drug or placebo. So overall, about a third of the patients responded, which is higher than the lower horizontal line, where a lower rate of response. But the difference is on the top line, there's no drug placebo difference. So the higher functioning guys were had a third of a chance of getting better, but it was just as likely to be placebo as drug. If you look at the kids with autism, there's a clear drug placebo difference, but the rate of response is lower. So if it worked there, you have a little more confidence that it's a drug effect, but the rate of response is closer to 25%. And that's the way I think about it, that classic autism, you've got about a 25% chance of response with a stimulant, which is very different from ADHD, right, which is, 75 or 80%. So if you're thinking about a stimulant, I think the clinical features of the case could influence what you do. If they're higher functioning, you're going to be more likely to take a chance. And altogether, about 50% of the kids responded to some dose of methylphenidate versus 80% in neurotypical ADHD. 20% dropped out of the study due to irritability. If this was an ADHD study, that might be 1 or 2%. So a lower rate of response and a higher rate of side effects. So, then you get it. Is it the same as ADHD? You don't know. But it's certainly not the gold standard drug treatment the way it is in ADHD. So that's still the largest controlled study of a stimulant in ASD, and I think that the results are pretty accurate in comparison to what we see on a clinical basis. Atomoxetine, which we talked about this morning, a norepinephrine reuptake inhibitor, that real child psychiatrists don't find as helpful as stimulants for typical neurotypical ADHD, but because we only get a 25% hit rate in ASD, maybe it's a little more useful for us. So what have we learned about Atomoxetine? So this is a study from the Netherlands, the largest published study so far. 100 kids, 10 years old, IQ above 60, so relatively higher functioning, 8 weeks of drug or placebo, and they used a good outcome measure. Now, they started at a dose higher than I do, and they went up more quickly than I do. So I kind of look at that. It's a little different from what I would do clinically, but that's okay. If you look at changes in inattention and changes in hyperactivity separately and combined, it's interesting. So you have the Atomoxetine group, 48 subjects, the placebo group, 49 subjects, and then you look at the total score, and you see the Atomoxetine group goes from 40.7 to 31.6. That looks like a meaningful drop, you know, especially compared to placebo, which dropped 0.3 points. That was a significantly different drug-placebo difference. If you look at inattention, you say, well, yeah, maybe it's different statistically, and it is, but it doesn't get you too excited, just looking at the numbers. If you look at hyperactivity, it looks more robust. And in fact, well, we'll save that for the punchline, but so that's interesting in that the relative improvement between hyperactivity and inattention may be different. I don't know if you know this scale called the CGI, the Clinical Global Impression Scale, but it's what most people that do psychopharm research use as the global improvement. Like, are they better or not? You know, you use scales to measure certain symptoms, but this is like overall, including everything, parent report, ratings, your clinic, are they better or not? You know, and we consider responders to be people that get a score of much improved or very much improved. That's a responder. Anything below that is a non-responder. So if you're minimally improved, that's not good enough, okay? And if you look here, you say, wow, nobody was very much improved that got Atomoxetine from the beginning to the end. There was nothing like, whoa, you know. And there were 9 out of 48 where it was much improved, meaning we'd probably keep him on the drug, but it could be better, so it's most of the changes are still in the no change range or minimally improved. So it's not like a powerful, robust, exciting kind of response like we saw with risperidone for irritability, for example. Side effect-wise, not surprising, some GI stuff, but otherwise very, very limited side effects. And then the summary is, I think, accurate. In ASD, the effect of Atomoxetine for hyperactivity is better than it is for inattention, whereas in ADHD, they're the same. It affects the two symptom groups the same. If you look at the magnitude of the improvement in ADHD symptoms, it's bigger in ADHD than it is for ADHD and ASD. So I think that all resonates with what we see clinically. It's a reasonable medication to start with. You're rarely going to make patients worse. I should repeat some of what I said this morning, I guess. The starting dose for me is 10 milligrams a day, and I go up by that amount each week. I start very low with everything, and the size of the patient does not affect the dose of drug for me, or the rate of titration. I just start the lowest dose, I go up on a weekly basis, and that's it. So you should say, well, I should be giving that talk then, McDougle. What's so hard about that? Well, it isn't hard. You know, people that know what they're doing keep things very simple. That's the way you do it. So don't think as hard, don't work as hard, do it simpler, and relax. Have a Starbucks, pay $120 for it if you want to. I'm with Neil Young on that one, so I'm a big Neil Young fan too. So he's got this album out related to Monsanto, and he really trashes Starbucks. So thank goodness I'm a Dunkin' Donuts fan. I don't feel better if I pay $100 for a cup of coffee than if I pay $2.42. I don't feel better. I won't get into this. I got to stay focused, although I've got a lot of thoughts about it. Well, I have to say a little bit. So I live in Boston, you know, like real Boston, like Beacon Hill. Like if you're going to move to Boston, and live in Boston, for God's sake, don't live in a suburb. So there's a lot of young people in Boston because there are a lot of colleges. They're all over, and I like it because it makes you feel younger. There's an energy to it. I'm always the oldest person anywhere, on the T, anywhere, but I don't think of myself as old. But the kids today do not want to be individuals. And I'll say particularly the women, because that's just they all wear this uniform. I don't want to get picky, but it's the same uniform. They all have straight, long, brown hair, about this long, straight. They even straighten it. My daughter has the most beautiful hair I've ever seen in my life, like a lion mane, and she straightens it. It looks like a got out of the pool. I mean, she's beautiful. And you know what I'm trying to get to here. Then they have boots on that are almost right below the knee, black or brown. They're wearing those black pants that are, whatever you guys call them, tights or something, or blue jeans. They're tucked into the boot. I'm not making fun. I'm just describing what I see. Then they have a winter coat, and that one that's got some kind of a circle there, whatever that is, means expensive. I don't know the name of it. Okay, that's fine. It's just, goose, something about a goose. And then they're all carrying a cup of Starbucks coffee, not Dunkin' Donuts. So it just strikes me that, like, who's going to wear a bow tie around here? What's the deal? Let's see some leadership. But anyway, I can't help it because there's so many of them, and it's just like a uniform. My daughter's the same way, I guess every time you think that way, it reminds me to say that it means you're old. It's what it really means. So I remember when people said that stuff about my generation, right? It means you're old. So I'm trying to accept it.
Are you trying to convince your daughter to wear a bow tie?
She doesn't really listen to me. It's because she's normal, right? Yeah, well, that's a good point. There is something to do with a bell-shaped curve. There's a reason people do things the same that are in the middle. But, what I do for a living is so far from the middle. I went about as extreme as I could get in my patient sample. So average does not increase my heart rate at all. But that's a good point. They're more normal than I am. So I think you get the take-home message here. I think if they had started slower and gone lower and gone longer, they might have seen a bit higher response rate. But generally, I think the results reflect reality. Alpha-2 agonists we talked about a fair amount this morning, if you remember, guanfacine and clonidine. And finally, we have some placebo-controlled data on this. This is a group I work with, a multi-site group called RUP, Research Units on Pediatric Psychopharmacology. It's a federally funded network. And we did the methylphenidate study, we did the risperidone study you're aware of, and then this is one we did with guanfacine, extended release guanfacine, so Intuniv, for ADHD symptoms. And this this was published this summer, summer of 15. 62 kids with significant ADHD symptoms, 8 weeks of drug or placebo. And we saw a 44% drop in the ADHD rating scale with the drug from 34.2 to 19.3. So that looks like a drop. And versus placebo, which was 13.2% drop, 34.2 to 29.7. So that was a powerful difference. And this just looks at the ABC hyperactivity scale over 8 weeks. It doesn't look dramatic and it isn't dramatic, although it's highly significant. The blue is placebo, really no change, and the red is what you saw with Intuitive. This was a different way to look at it with more robust response. If you remember the CGI, that's the way to think about this. 15 out of 30 of these kids were responders. They were much or very much improved, where only 3 out of 32 that got placebo were much or very much improved. So it really kind of shows up here. The modal dose for the study was 3 milligrams, you know. It comes in 1, 2, 3, and 4. 4 is the max. You start at 1. It's a capsule. It's extended release, so the child has to be able to swallow it. I don't know if it's better than generic guanfacine or the same. In my practice, I start with generic guanfacine still. It's cheaper. It's just what I do. I guess on occasion I might flip it over to the long-acting, so you don't have to take it as many times, but probably I leave them on it. So this has also been shown to be much better than placebo for neurotypical ADHD in some bigger studies. So that's the largest study looking at an alpha-2 agonist in ASD. Side effects, certainly you can see sedation. You can see this sort of cheerfulness, sadness kind of thing like you can see with a stimulant, irritability. With regard to vital signs, the blood pressure readings went down but came back to baseline at 8 weeks. Heart rate remained 10 points below baseline at week 8, but it wasn't of a clinical concern. It was probably elevated at baseline, and no significant changes on EKG. So fairly clear outcome here, about a 50% rate of response. So if it's 50 and atomoxetine's maybe 33%, stimulants 25%, that's kind of what we have to choose from. So you can see why this kind of drug might look better in our hands than a stimulant versus ADHD out in the real world. Joni Mitchell, I don't know a lot about her, but everybody and their brother dated her. I can tell you that. I mean, I read about these 60s and 70-year-old, from the 60s and 70s rock stars. They all dated Joni Mitchell, and they all dated Carly Simon. So that's all I can tell you. It's true, though. I like Carly Simon, her voice. I like powerful female voices. I don't know if you do. But like Whitney Houston, I mean, it's just powerful. Barbra Streisand, powerful. I love it. You know who my favorite female singer is of all time? Karen Carpenter. I just love it. Because she used to be, well, she's a drummer, you know. And so she was growing up in New Haven, Connecticut with her brother, who was a piano prodigy. You know, he was all the attention. And here she was sort of like a tomboy, whatever. Oh, she played the drums, which is kind of unusual for a female in the 60s. But then when they became a group and act, you know, here she was sitting behind these drums that you couldn't see her at all, and they wanted to get her out front. So they're like, well, you got to sing to be out front. So she put her mouth right by the thing, and it looked like she was barely even talking, but the sound was. So anyway, Karen Carpenter, if you're in a bad mood, listen to the Carpenters, and you'll just feel really good. That's all I can tell you. I've had women in my life in the past that didn't want to go with me anymore because I liked the Carpenters. You know, like, well, I don't really, you can imagine what I said. Or Barry Manilow. I love some of Barry Manilow's songs. I can't help it. I love some of his songs. You know, there's that part of me. But, why not Led Zeppelin? I'm like, how about the Carpenters? You know, I don't really care. Irritability. So you know this stuff. Aggression, We covered a lot of this morning. How many of you are here for the first time? Maybe a third. Okay. So some of it you've heard, but it's a couple of points are important. The bigger you are, the more damage you can do. That's because we're talking about adults in here, and we're talking about weight gain. If you gain a lot of weight, you're going to do more damage in aggression, and these drugs cause weight gain. So you need to think about all of that. I'll try to pay more attention to you guys. I'm not doing a very good job of orienting, joint attention or something. Irritability, let's talk about it. Well, you have antipsychotics and mood stabilizers. And antipsychotics are hands down the most effective, no question. It doesn't mean you always start there. If you want to be more conservative, start somewhere else. If you feel you've got more time or it's a young person, start with something else. But if you need to treat it right now, in the next 10 minutes, then you probably ought to get an atypical antipsychotic. So the older drugs can work. Haldol's one of the best studied drugs ever in autism. Back in the 80s, the pioneer of psychopharm in autism is a woman named Magda Campbell, who was at NYU, and she had an inpatient unit where she just did studies and demonstrated that very low dose Haldol was quite effective for irritability in kids with ASD. So it works. You know, I guess when the atypicals came out, we all thought they were going to be better because there might be less TD. I think that's what we thought. There might be less TD. These can certainly cause TD. But we got then hit with the weight gain and the metabolic disturbances that I don't think were as big a concern with the typicals. I never remember hearing that in the same way. So, you know, what's worse? Neither one's good, but they're not miracle drugs, as you know. But there's a role for them. Thank goodness we have them. And we'll go through these a little bit. So this was the first risperidone study in kids, research units on pediatric psychopharmacology. It was multi-site, NIH sponsored. 101 subjects, 4-to-1 boys to girls. That's what autism is, 4-to-1, the gender split. Nobody knows why. That's an important thing. Some of this stuff really bothers me. I can't help it. So there are some things that are so important that people gloss over, and most of the rest of it's a bunch of nonsense. This is important. Why is it that there's more boys than girls? That's important. That answer is going to tell us a whole lot. We've just sort of accepted it. You can immediately think of all kind of reasons why. Some are true, some aren't, but we ought to investigate it a little bit more. This one guy I work with, he came on board. He had been in private practice for years, and he wanted to give back, you know, to the field in a way. He had a son with high-functioning ASD, and then he comes to see me. He goes, I want to do research. I said, all right, let's meet and talk about it. And I said, there's about 3 things that are important. The rest of it's a waste of time. So I'm going to lay it out for you. He goes, what's that? I go, the sex difference is important. You know, I'm talking about really important. What else is important? Understanding regression is very important. I'm talking about trying to get to etiology. Understanding regression is very important. And understanding why people with autism don't talk is really important. I go, which one do you want to do? He goes, I'll think about it. Sent me an email. I want to study subtle differences in prosody among high-functioning Asperger's with this machine they have in England. I said, we're done. You do not hear feedback. You don't get it, right? So I can't supervise you because I'll kill myself. So that's just the truth. You know, here I am, I'm trying to lay it out. And you know, if you want to do this for a living, you got to get into it and do it. It's not a fun thing. It's superficial. But anyway, that's not what my mentors were like, okay? So anyway, back to risperidone. So all the kids were really irritable, really aggressive. 8 weeks, drug or placebo. The final mean dose was 1.8 milligrams a day. That's pretty close to clinical reality. I would start at 1/4 to 1/2 milligram a day and go up by that amount occasionally. We said this morning that drugs that don't have side effects don't work. That's still true. If you're treating real aggression or psychosis, the drugs are going to have side effects. There's no have my cake and eat it too. That's just not there. So what are the main side effects with risperidone? Increased appetite and weight gain. So they're getting bigger. And then associated medical comorbidity. Or if food was being used as a reward and you're now withholding it, that could lead to somebody being upset. But it works, you know. It works pretty well if you need it. So here you see a 70% rate of response with drug versus 12% with placebo. That's a big difference. Weight gain, right. Sedation, that's usually transient. Usually in this situation, sedation is welcome for a few days, for everybody. It's not a bad thing, and it wears off. But you don't want drooling. You don't want drooling, and that's usually dose-related. We saw very little extrapyramidal symptom issue. Again, it's a shorter-term study, low dose, but I think reasonably well tolerated from an EPS perspective. Back to the idea of you're interested in irritability, but you want to see what else it might have helped with. So look at, you can see the slide. If you look at risperidone irritability baseline to endpoint, wow, it's a meaningful drop. Look at placebo, not much. Okay, I see. Social withdrawal, wow, maybe that looks pretty good. Well, it was statistically significant until we went back and did a correction for multiple statistical tests, and then we lost it. You'll say, well, I see kids where their social withdrawal is better with risperidone. Well, that makes sense to me. If you're less irritable, you're more available for social interaction. I understand, but we never want to say a drug helped with social impairment and autism until we're darn sure. And we're talking about the core disturbance, because that'll be front page news. And you've seen it before. And what happens is that company goes out of business, and there was another one. So we don't want to be on I was taught you don't want to be on the front page of the New York Times, ever, because it's usually not good. You don't want to be. Be very careful with what you say, and, lay low. If you're going to be in the game a long time, lay low. So I try to lay low for the most part, right? So social withdrawal, it might have been secondary improvement. Let's call it that. Stereotypy, yeah, it was better. It's again, motor movements are often driven by dopamine. So if you're blocking dopamine, you could see some improvement in repetitive behavior. Hyperactivity definitely got better. Well, that's just common sense. You're getting a hammer out, and you can reduce hyperactivity with a hammer. It doesn't mean it's clean. It's due to side effects primarily. And we didn't see any improvement in their speech in a meaningful way. This was a study that I think an important study. To apply for the grant, you had to have both a drug component and a non-drug treatment component, which is what you think is ideal in the real world. So we all went in with that, sort of risperidone and a behavioral approach, which we let the behavior therapy people determine what that should be and teach us about it. So they used parent management training combined with risperidone. So one group got risperidone and like an educational approach, and the other group got risperidone and parent management training to see what would happen. 124 subjects, that's a big sample. They got 11 parent management training sessions. And we were looking at compliance, irritability and compliance as outcome measures. And the combined group was better than risperidone alone for irritability, repetitive behavior, and hyperactivity and noncompliance. So combined was definitely better. And you could use less of the drug in the combined approach compared with drug alone. So those are all good things. Those are all good things. When we looked at what happens to the subjects when you discontinue drug at the end of 24 weeks, stop the drug, the hope would be that those that had behavior therapy would continue to do well. They both relapsed dramatically at the same rate. So what does that mean? I don't know. It means you need continued ongoing treatment one or both, or you need a longer period than 6 months of the behavior therapy. But it went against what we had hypothesized. Aripiprazole, the other drug that's FDA approved, there's the only studies that are published that are of a reasonable size are done by the company. So whether that's good or bad, we need to have an independent study. We actually did a study. It's done, and we're trying to get the data ready to look at. But these were big samples. This was a study of 98 kids and another study with over 200 kids. It's the largest drug study ever in autism. And the other thing here is the overall rate of response was a little bit lower with aripiprazole, but you have to remember that a number of the kids in this study had already received risperidone and either not responded or had side effects. So it's not the same sample. You see, it's biased as in a more refractory sample. That's important to remember. But we talked this morning about the starting dose of aripiprazole, 2 milligrams or 2.5 milligrams, no higher. What about 5? Nope. 7.5, no way. They're big. We got to get better in a hurry. 2.5, 2. Okay. Or you're going to run into akathisia and stop the drug, and you don't want to do that. Go up by that amount every week. It's an effective drug, you know. Which do you pick first? Well, usually we don't have a choice. They've had one or the other, probably both. This is probably better in the ideal world side effect-wise, but if you have to get somebody better now, then I would lean toward risperidone. That's my clinical sense. This reduces prolactin rather than increases it, so you don't see gynecomastia, milk letdown, problems with bone mineralization, sexual dysfunction. That's a benefit. But they can both be effective depending on the patient. You can see weight gain with this. When it first came out, we were told it wasn't going to cause weight gain. In part, that was because the data that the company had at the time was in adults with schizophrenia and bipolar disorder. They didn't have any data in kids, and there wasn't much weight gain in adults. There is more weight gain with these drugs in kids than adults. Then the kid data started emerging, and we saw that, in fact, there is weight gain with Abilify. As much as risperidone, I'm not sure. Close enough, you know. Not always. Sometimes you lose weight, but I'm making general statements. But this is the big study, 218 kids. It's still the largest drug study ever done in autism that's published. And here it's called a fixed dose study, meaning you had to sort of stay on the same dose the whole time. You couldn't move it based on side effects or response. You know, you just, because which dose, what's the lowest effective dose is what they're trying to determine. So you get 5, 10, or 15, and let's see what happens. Well, all 3 doses were better than placebo. So it didn't tell us a whole lot, really, but 5 worked as well as placebo. But I'd say 5 sometimes works, but maybe an average dose is 7.5 to 15 or 20, you know. I said this morning that if you have to go above 20, you're probably not going to see much more benefit, usually. I don't anyway. So starting dose is important here, avoiding akathisia. That's the most important point. Yes?
There's less discontinuation on the higher dose.
Say what?
It says there's only 7% discontinuation on the 15 milligram dose.
Yeah.
Higher than the 10.
There were some findings in this that were counterintuitive with regard to the highest dose and the lowest dose. That didn't make a lot of sense. So I'm trying to translate it for you into reality. Paliperidone, the only reason I have this here is we did an open label study with it, meaning we all knew they were on the drug, and then we did ratings, but it was young adults, adolescents and young adults, so kind of a pertinent group. And many of them had risperidone. That's why it's interesting. Because you might say, well, there's no chance that a metabolite would work if risperidone didn't. And, well, that's sometimes true. But in this case, a number of these guys actually did quite well. 20 out of 24 were much or very much improved with irritability. So there hasn't been a placebo-controlled study. It doesn't mean much, but it meant something to me from a clinical basis. It would be rare for me to ever prescribe it. Is it better? Is it safer? Probably not. Does it work better? Probably not, with a big sample size. This is the drop in irritability in the paliperidone study. Well, it can be effective. Olanzapine, very few studies in autism. The take-home point here is weight gain. So in 8 weeks, the guys on olanzapine gained 8 pounds, pound a week. If it would have kept going, it would have kept going. So at least in my hands, among the atypicals, olanzapine causes the most weight gain in kids. Maybe clozapine, but I'm talking about the ones you use. It can be effective for irritability. Not everyone gains weight, all of those caveats, but it can lead to significant weight gain too. So I tend to use less of it. I would use risperidone, Abilify, quetiapine, ziprasidone ahead of this, let's put it that way. Then I would use this, then I would be clozapine, that's it. I don't use any of the newer drugs. I don't have time for learning that. They're no different. Until you got something better, let me know. Otherwise, I don't care. Latuda and this stuff, I don't even know how to spell it. It doesn't matter. They're no better. So until you bring me something different, I don't have time for it. That means you're old too. Lots of things are pointing in that direction, but I don't really care. I can get you better without that stuff. Let's put it that way. This is quetiapine, so no controlled studies, so it's dirty. Various age ranges, doses all over. It can be helpful. I start pretty low, 12.5, 25, but I go up as high as I need to. It's sedating. It can wear off. If it's sedation that's sedating, if it's not interfering, that's not terrible. It can help with anxiety. I wouldn't use it for anxiety alone or sleep disturbance alone, but if there's comorbid irritability, that'd be great. So I wouldn't throw this out quickly. You can see weight gain, but there are times when other things don't work, and this does. Ziprasidone, I said this morning I'm using more of this than I used to. When it first came out, the word was it doesn't cause weight gain. It doesn't cause weight gain. That's true. Generally speaking, it's the only atypical that doesn't cause weight gain, which is a big deal. You see these guys just blowing up, and you get tired of that. This doesn't do that. So then the question is, does it work? And it depends on the patient, but I'm starting with this quite a bit now because of the weight gain. Well, how do you use it? I use it the only way I use drugs. What's the lowest dose? 20? Let's start with that. All right. How long? A week. Then what? Increase by 20. Until they're better, And some of them do quite well at 40, 60, or 80. They do. What about the cardiac concerns? It can cause sudden death. Show me the cases report. There aren't any. How long's it been out? 10 years? 15? There's no reports of sudden death. So what happened? That was all marketing. If you were the other companies, and here comes a drug that doesn't cause weight gain, and yours does, guess what? You can kill kids. That puts a chill through you. I'm telling you the truth. So there was, a lot of concern about it. The FDA doesn't recommend an EKG at baseline or with treatment. Does that tell you something? Okay. So if you want to get a baseline EKG, do it. I don't give it to anybody with cardiac problems. But otherwise, I think it's worth a try because of the lack of weight gain. Some kids won't get better, but some will. These are just other open label. There's no controlled data at all. Clozapine, you're going to rarely use this, hopefully, in your practice. One place, if you have extremely refractory self-injury or aggression, you might use it. The downsides are it can lower the seizure threshold more than any other antipsychotic, and a quarter to a third of our guys will have seizures. It's sedating. It causes weight gain. It can cause trouble swallowing. You have to get blood drawn frequently. It can lower the white count for a person that may not be able to feel that or tell you about it. So lots of potentially scary events, but it can be effective in cases where other things haven't worked. The place I've used it 3 or 4 times is in patients with catatonia. So there is something called catatonia. You only have to see it once, and you'll know what it is. And it'll scare you because it's such a dramatic clinical presentation. And we were talking about it a little while ago. The cases we've seen together, they're all young adult men with classic ASD, every one of them. So it doesn't mean all those guys have it, but that's the only type of patient we've seen where it's occurred. So 18 to 25, minimally verbal, adult, classic autism guys. And the bottom line thing that we would agree in common is they have trouble starting and stopping. They get frozen. They'll get frozen in a place for a long time. They have trouble initiating things, like getting going, walking, or stopping things. So it's quite striking when that change has occurred. At least think about it. And if you read the literature, it'll say, because catatonia is something that occurs across psychiatric disorders, right? I don't think we really know what it is neurochemically. I've got ideas. But it does certainly feel a little bit like a dopamine depleted state, kind of like Parkinson's, a little bit of a feel like that. And the literature will say start with high-dose benzodiazepines, lorazepam, which you should. That's pretty safe. You can get to doses of 14 to 20 a day, and they're not tired. But that can be effective, or not. I haven't found it in my cases to be effective yet, not effective enough. Then it would say try ECT, which maybe it works according to the literature. You know, you're into other issues there. You're into, well, what if the patient lives in a different state? That happened to us. They lived in Connecticut. We brought them to Massachusetts to do it because they wouldn't do it in Connecticut. Well, the lawyer said you can't do it in the state because they're cognitively impaired, you know. And then that can get in the way. You got to get approval from a court, a judge. The other thing I worry about is what if it works? Then what are you going to treat them with? Because you don't really know what caused it. Like, is it psychotic depression? What is it? So you might be doing maintenance, you know, there's all of that. So we've used clozapine in these cases because regular antipsychotics can make them worse. Kind of like Parkinson's, if you think about it, right? If you're giving a dopamine blocker in a dopamine depleted state, you could make symptoms worse. Not always, but you can. So, but tread caution, refer them to the young doctor first, because he's seen quite a few cases, and I think you'd want to have somebody else with some experience evaluate them. Mood stabilizers, you know, they work for irritability and aggression and some other psychiatric disorders. It's logical that they would work here. They generally don't. I mean, as a rule. There's no large controlled studies of any mood stabilizers for aggression in ASD. It doesn't mean they don't work. You're going to have patients where they work great, like I found it, but it's going to be scattered, okay? If you have a clear family history of bipolar disorder and you've got cyclical behavior, it can be a miracle. But, you know, I maybe have 2 patients out of a lot of patients on lithium where it was like the lock. Maybe I have, I don't know, I'm making it up, 10 patients on Depakote, but it's not a lot out of hundreds. But occasionally it's the only thing that worked. So you want to try it. Maybe safer than an antipsychotic if you want to try it first. Or I work in a teaching hospital, you know, they want to try it. I say, go ahead, try it. Didn't work, Dr. McDougle. Well, okay. You tried it, yeah. All right. But don't go for this stuff about, there's this new drug out, it's really safe, I'm going to try it. Not for psychosis or aggression. It's not going to work. If you see a response, you're delusional. Or the next patient you treat, you won't see it, or it won't last very long. All right? You have to have some pop to treat really serious symptoms. One day, I don't think anytime soon. You know how people talk about, so that somebody this morning, they said they like my talk because I don't use hyperbole to defend the field. I don't do that. I talk about what I think is what I see clinically. But you know, this idea of disease-modifying drugs, like we're going to treat adults with Fragile X and reverse cognitive impairment. No, we're not. That's a lie. Yeah, they've tried it. You know, the drug placebo, there's no difference. That's front page New York Times. That's where I was. Companies are out of business. It's not going to happen while we're alive. I'm not like a downer guy. I'm trying to be realistic. That's not going to happen anytime soon. We can make incremental steps in making drugs a bit more effective and safer. But disease modifying, if you're talking about reverse or cure, not while we're alive. So I'm just trying to get it more realistic, because the point of that is you guys can do as good a job as I can. There's no magic in academia where we're about to break something loose. There's nothing like that. But we can do a lot better than we did, a number of years ago. I don't know if you know Maynard Ferguson, but, well, he's dead now, but he's unbelievable. I mean, if you like trumpet, oh my God. We were like freaking about him in high school because he was so good, but you may not care, The other guy that's really good is Chuck Mangione. Yeah, really good with a flugelhorn, just pure, beautiful, mellow sound. So I was in a group in high school. So what was high school? It was like when Chicago was popular. So you had like drummers and guitar guys, but also horns and stuff. It was acceptable. We were so bad, man. We had business cards. I don't know why. Silver Satin Skyway. That was the name of the group. I remember playing one wedding where we had like an inside track, and I think a high school dance. That was it. But anyway, I don't know why I said that. That was Maynard Ferguson, man. Unbelievable. What's that called? MacArthur Park, that song? Oh my God, it's just. So here's my funeral. It's going to be no casket, no bodies. I don't want weeping. I don't want any of that stuff. You're going to walk in, you're going to sit down, there's going to be a stereo there. And you're going to listen to an hour of my favorite songs and then leave. And that's it. I'm serious. Because that's really what makes me feel so good is certain music. And I hate that kind of dead, sick, crying crap. You listen to my music and then leave. Period. I don't want to get into the certain songs. I haven't gone that far yet in planning it, but there's a number of them. You can imagine some of them. Couple Marvin Gaye. So anyway. I'm trying to liven it up a little because it's, in the afternoon and everything. Say, keep going. Repetitive behavior. So we talked about this morning. This is not OCD. The repetitive behavior of autism is not OCD. A lot of people call it that. Don't call it that. It isn't. Well, what do you call it? I call it the repetitive behavior of autism. I don't know what else to call it. It's stereotypic behavior. It's flapping and rocking. This is purposeful. It's not a compulsion. I mean, this is non-purposeful. Compulsions are purposeful. Compulsions, you don't want to do it. These guys want to do it. It feels better. It's not necessarily a symptom you want to try to eliminate. Parents want to eliminate it, some of them because they're embarrassed by it. Well, then you have to educate them and say, he's doing this to feel better. I know, but I live in the fancy suburb, and when I go to the grocery store, all the ladies stare at me. I know you don't want to hear what I have to tell. It's a recommendation there, all right? But, be proud of your child and his differences. But throwing drugs at that is not going to change it. They're trying to help themselves. It's a stereotypic behavior. Well, if it's part of autism, shouldn't it get better? Like shouldn't the language get better, the social impairment and the repetitive? That's what we say autism is. None of it gets better with the drug. None of it. Well, what the hell are we trying to treat then? That's where I've gone lately. Because read the DSM, man. Panic disorder, you know what it is. It gets better. The symptoms go down. Major depression gets better. Schizophrenia, everything gets better. The things you define, don't they? What about autism? None of them get better. Give me some ideas on that. Yeah, I'm serious. It tells me that we've described something that's become a big business that isn't like other brain disorders, where there's symptoms and treatments that get the symptoms better. It doesn't. Nothing. Isn't it interesting? You kind of with me? Give me a little. It's weird, though. So what should we be treating in these guys? And then is it even autism? You know, I've said this morning, I think we have too much confidence in what we think we know. We don't know anything. These are disorders of social development, period. That's about all I can say. This stuff doesn't mean much to me. You know, we see people with Down syndrome who are very social, who have stereotypic behavior, and they come referred with a comorbid diagnosis of autism, and they're as social as can be. Because we get distracted by some of this other stuff that's pretty unusual, that we think is kind of interesting, that we link to autism, but it shouldn't be linked to autism, because it can occur in other disorders. And I always look, the social impairment has to be front and center for autism. So you start rethinking it a little bit. Why is there an explosion of this? Because everybody and their brothers is on the spectrum. Now think about it. If you don't know what the hell it is, you can get away with saying that. People say, yeah, it is, probably right. How long did it take you to diagnose that? 10 minutes. He's on the spectrum. And you know, fight against that a little bit, because it's not true. We're all on the spectrum a little bit. I'm way on the spectrum. But that's just okay. In medicine, you end up, you study what you've got, and it'll kill you in the end. There is something to that. If you know people, like I know guys that are specialists, right? They study what they've got, many of them, not all, many of them, because they are drawn to it, because they can experience it and they can treat it. There's something to it. Well, I switched from OCD to autism. I do not have OCD. I would tell you if I did. But I don't want to talk to you when I get off the stage. Why not? It's not rewarding. I'm just honest. It's not rewarding for me to talk to anybody. Well, that's pretty narcissistic. Well, maybe so. I'm just telling you the truth. I don't like to BS people. Well, how can you run a big department and do all that crap? I can do it. I can do it, man. This doesn't make me anxious at all. But I just don't, when I get off the stage, I don't want to talk to you. Are they taping this, by the way? I don't really care. I don't care. I am who I am, you know. Well, you get to a certain point in age where you don't fear. You know, so many decisions are made by people out of fear, especially in academics. And colleagues of mine that I've respected for years, I better be careful. When it's on the line, though, and it's, are you going to be a leader and protect the team or throw the team under the bus? That tells you something. It's like being in combat. So I believe in loyalty and team ahead of me, baby. But there are people that don't do that. And that really is disappointing, really disappointing. So if you've had a good friend for a long, long time and they're still there, value it, because it's relatively rare. So all that to say that there's not a lot of OCD in autism. Now, can you have OCD in autism? You can, because it occurs in 2% of the population or something. It's going to be difficult to tease out from the repetitive behavior of autism. And if they can't talk about obsessions, if they're nonverbal, you're disadvantaged. So to me, it's got to look kind of like classical OCD. If you've got someone that's grooming and washing, it's hard to say it's not OCD. You know, if their hands are chapped, and you'll see it on occasion. Well, what about hoarding? Well, it may not be hoarding. It may be collecting. They may want to collect. That's rewarding. That is not what hoarding is. Very different. So you don't want to get locked into, because of a similarity, into a diagnosis or treatment approach. You want to be more sophisticated than that. Is it rewarding to the person or not? Yeah? Ordering and arranging things. Well, that's how their brain works, man. It's easier to understand the world if everything blue is in blue and red and straight. It's true. So that's not something they don't want to do. God, I wish I didn't have to think about Star Wars. Oh my God, I wish I didn't have to think about it. That's an obsession. What do you call it then? You call it a preoccupation. A preoccupation, we all have preoccupations. What's yours? Name one. Gardening, jazz music, country fiddling and dancing. Name one then. You have to name one. Reading. Reading what? I'm all specific. I'm not magazines. You know me. Give me one. Vogue. All right. I understand you. Not in a negative way. I know I understand you. And we all like to do certain things. He's not obsessed with that. He's preoccupied with it. He doesn't want to, oh my God, I don't want to read Vogue. Keep it out of my head. You know what I mean? So that's very important to use the word preoccupation to describe what these things are. They're not obsessions, because it gets you down a path and that treatment doesn't work. You don't care what my preoccupations are, but I'll tell you anyway. The Beatles. I have a driver's license. I'll show you, ma'am. This is my driver's license. It went through customs. See it? So it's John Lennon. It works at the Toronto airport. But I like the Beatles, you know. It's not their music, it's them as people that I really am drawn to, reading about them. I like Indiana University basketball. It's hard, if you grow up there, that's part of the deal. And they're in first place in the Big Ten right now. And I really, really like Neil Young, too. I totally love Neil Young. The young man is a nice man, the organizer, but he doesn't know quite how to handle me. I make him nervous on like the time and stuff. It's okay though. It's his job to keep me in line, but it's okay. You'll enjoy it more this way. I could do this talk if you want me to, but you don't want that one. SSRIs, they work for OCD. It's the only drug that works for OCD. They don't work for autism as a general statement. Let's look at the data. So fluvoxamine, 12-week study, drug or placebo. 1 of 18 kids that got the drug was a responder. 1 out of 18. What happened? They got worse. They became behaviorally activated. I did this 20 years ago. And look at the final mean dose, 107 milligrams. What's the maximum dose of this drug? 300. Well, you didn't go high enough. We couldn't go any higher because it was causing behavioral activation. So poor tolerability and very low response. So this is when I had a good feeling that this stuff doesn't really work. And everyone else was running around saying, oh, this is what you use to treat repetitive behavior of autism. Well, it's not, and time has shown that to be true as a broad statement. That's when people were into the OC spectrum, right? Well, if it's repetitive, it gets better. Well, that's just damn simple. So straighten up, right? This is liquid fluoxetine. It worked a little bit better than placebo, but not for any of the core autism features at all. This is the biggest controlled study of an SSRI, citalopram, 150 kids trying to treat repetitive behavior of autism, drug or placebo, 12 weeks, a good group, no difference. More behavioral activation. That's pretty powerful. This is a big study of fluoxetine, 158 subjects, no drug placebo difference. So probably true. It doesn't mean you're not going to have occasional patients that do really well on it. I don't mean to say that. It's when you look at big samples, it doesn't shake out. There's some kids in there that responded and did well, but not enough. In adults, however, fluvoxamine better than placebo. We did that study. It was the first SSRI study ever done in autism, published in 1996, and it was with adults, which was interesting at the time. And here's a fluoxetine better than placebo in adults. So I think in adults, they tolerate the drug better, so you might be able to get to a dose that might be effective. I don't think it's a miracle, but if you have adults with ritualistic behavior that's interfering, I think it's worth considering. But in kids, not so much. We don't really have a drug that works well for repetitive behavior of autism. Avril Lavigne, where did they tell me she was from? Ottawa? Huh? Tell me, say it loud. Napanee. That's what they said this morning. I said, that's in Indiana. Near Kingston. Just take me to the cellar door in Yorkville. And see if we can find Neil. That's all I want to do. Come to Toronto and everybody tells me, oh, Yorkville's not Yorkville and there's no cellar door. Good luck finding Neil Young. Well, hell, man, I had my heart set on it. They're like, go to the Queen's something. Walk around the art galleries and pretend there's hippies around. Take the train. Take you right there. Okay. Sleep disturbance. Major problem in ASD. If you can't sleep, your behavior's worse. You can get outside of the house at night and get into trouble or die. You're disrupting other family members. When you're awake, you're in the parents' bedroom till you're 22. So it's not a minor problem. Start with melatonin every time. Go to the drugstore, buy 3 milligrams. I just wrote it on an email in between talks. Buy 3 milligrams, give it for a week. If it doesn't work, go to 6. If it doesn't work, go to 9. If it doesn't work, that's it. But start with melatonin. What do you do next? Well, I would go to trazodone next. It's the most effective sleep aid I have. Start at what dose? 12.5, 25? Go up to what? Max of whatever you want, 150. Go slowly. It'll work quite well. Clonidine can work for a while. But I think over time you may learn that its duration of effect begins to wear off. They're going to start waking up in the middle of the night. Not always, but you might see that. Then mirtazapine, Remeron can be helpful for sleep. If they have sleep problems and big-time anxiety, it's worth a try. It can cause increased appetite and weight gain. That could become an issue. Amitriptyline is a drug that is of historical significance to many of you, a tricyclic antidepressant. It can be very helpful for sleep, but don't go with it too early. Dry mouth, constipation, cardiac effects, lowering the seizure threshold, etc. Benadryl can work sometimes, but many times it can make the kids worse. Benzos can work at times. They can also make the kids worse at times. But if you gave me one drug out of the list, I'd take trazodone. Now, I don't even think twice about that.
What about sleep onset delay? Have you ever had any cases of that? Where you go to sleep at 6 in the morning
Oh,
and none of the drugs
oh,
get him there sooner?
you can't break out of it in a way.
It's wrecked his life.
Wow. Sleep onset delay. Kid that he goes to sleep at 6 in the morning, and you can't kind of reestablish the timing based on drug effect. I wouldn't know. It sounds like a real biological circadian issue, right? I don't know how you would change it. What do you think?
What I'm doing now is we've decided to change bedtime and rotate his day. That's all we can do.
Yeah. Well, I like that. So he basically, you adjust your living schedule to the sleep time his body wants, which I like that in general. Some of us are too rigid. And to go with what you can't change sometimes, there was a woman I was talking to earlier, sort of a psychosocial issue that wasn't going to change by forcing it. It's going to change maybe gradually, but it's too ingrained and too important for this patient. So sometimes you have to treat people as individuals. Melatonin's well studied, plenty of studies. None of the other drugs are studied at all for sleep, which is kind of ridiculous. Covered this, covered that, covered that, covered that, covered that. I don't know. That was one of the first albums I had. I don't really care for them, but Magic Carpet Ride, probably 69 or somewhere in there. Mood disorders. Well, I said this morning. Get the chapter out, go buy my book apparently, and look it up and say, oh, there's more anxiety and mood disorders and intellectual disability than in the rest of us. Maybe. So tell me about the studies. There aren't any. There's no studies of depression in ASD. Any age, any shape, size, country, nothing. Zero. Of depression? Right, none. Come on. No, none. That's crazy. Who wants to come and study it, for God's sake? Let's go. You know what I mean? Why didn't I do it? Well, let me say, what would I say? Recently, I'm getting into other neurodevelopmental disorders because I need a little bit of a change of pace. And so, and Mass General has these huge clinics for Down syndrome, Williams syndrome, Angelman syndrome, 22q, 15q, I mean big. So I said, and the guys that run those clinics, they're nice, they're good doctors, but they don't know behavior. They want help. They send them all to me. They're adults. I go, let's start a new clinic, like a neurogenetics behavioral disorders clinic. And then you start to learn the literature. There's nothing there, man. Down syndrome, major depression, nope. And trust me, they have it. These people are, I see a lot of adults with these other disorders. Young kids, 22 or 3-year-olds, when everybody goes to college, they get depressed as hell. I mean psychotic depression. And you can really do a good job knowing what we know. But you can imagine sort of out in the middle of nowhere, oh, I didn't know they could get depressed, and just sick. So just to help people and begin to generate some data, that's exciting to me. So I want to get into a study of depression and Down syndrome real fast. But Williams syndrome is fascinating. Almost the opposite of autism in that they're hypersocial. They're in your face. Here's me, Mr. Schizoid. And the world, the annual Williams syndrome conference was in Boston. And they asked me to talk about psychopharm, which is easy. There isn't any. But I go over there, and I sit down in the lobby, and all of a sudden there's 8 people with Williams syndrome sitting around me, like talking to me. And I'm not social, man. I don't want to talk. I give a talk, and then I'm like Chuck Berry. I bring my guitar. I'm in a Cadillac. I get out, go on stage. There's a group here, some other group, local group. We don't talk about what we're going to play. We're just going to start. It's over. I'm getting in the Cadillac and driving back to St. Louis, man. So help me. Williams. So here they are. Woo! But that's fascinating to me. Their main thing is anxiety, by far. I mean, extreme anxiety. It gets worse over time. So there's so much that we can do in beyond ASD that's just really rudimentary, terrible. But I'm kind of getting excited about that. But you're right. Why wouldn't someone do a study of depression in ASD? You'd have to start with higher functioning guys, I think, because when you guys take a history, you want to hear what they have to say. How do you feel? It'd be harder to start with nonverbal. You're guessing a little more. You're using neurovegetative symptoms. That's fine. But somebody ought to do it in, middle school Asperger's, for God's sake. Because middle school was terrible, if you remember. For me, it was. No interest in that. Just skip it. The same is true for anxiety. How many placebo-controlled study of anxiety in ASD? 0 in the world literature. And we all see so much anxiety. 0. Okay. So I don't have a lot to say on mood disorders. So I would say do what you always do. I don't have any other things to say. The challenges of diagnosing depression and autism. Bipolar, forget it, man. That would be a very difficult study to do because it's not particularly common. So to get a sample, it'd be very difficult. But if you see a lot of bipolar in your practice in ASD, you're making diagnoses that aren't there. You can do it, or you're using terms to describe symptoms that kind of look like it. If you want to do that, or you have to for billing, that's all fine. But just you're not really seeing true bipolar disorder, like a lot of it, because it's not at a higher rate. Avril Lavigne, really good. That one album was really good, like in the early 90s. Who did I say? Avril Lavigne? Sorry, Alanis Morissette. She's kind of an angry young woman. At least she used to be. That hockey player that kind of gave her a raw deal. Who'd he play for? You guys like hockey, huh?
She's from Ottawa.
Ottawa? Well, which hockey team do you hate? Montreal? Montreal? Or who do you really hate? Who's your rival?
Montreal.
Yeah? So he probably played for them. But jeez. Anxiety, same answer. Here's what buspirone, first drug for me. If you weren't here this morning, you're surprised at that because it doesn't work. But it works for ASD for some reason. Trust me. How do you start? 2.5 a day, half of a 5. Give it in the morning, give it when you get home for the day. 2.5, 2.5. Go up every week. and you're going to see at least 50% of them show improvement in their anxiety. Gradual. Mirtazapine can work. Comes in a 15, starting dose, 3.75, a quarter of a 15, really low, because you could get into activation if you don't do that. And maybe low-dose SSRIs work. You would know better than me. I just don't use much in the way of SSRIs. No one studied it for anxiety. This is the only thing there is in anxiety, an open-label study of buspirone. 8 weeks open label by the group in, I'll call it Holland. 8 weeks, 22 subjects, adolescents, mainly anxiety. They started way too high, man. 5 milligrams TID, that's too high. There's no reason. Start at 2.5 a day. Their average dose was 30. That's about where you're going to end up. About 15 twice a day will, above that isn't going to do anything. But you might also do well at 7.5 twice a day, 5 twice a day. But some people had marked response. So they're onto something here that's true. Many of the responders maintained their response over time. One kid developed a dyskinesia on, I would tell you that can happen. You can develop TD on Buspar. I've got a case right now. Well, the other thing you can see with it is elevated prolactin, which is probably the same mechanism. But we have a kid that developed, this was this week, marked gynecomastia on a combination of sertraline and Buspar. So I'm not sure which one did it, because sertraline can do it too, but I think Buspar is more likely to do it. It has more effects on dopamine blockade. But you want to, so you don't want to be surprised if you see it. It's not like, well, that can't be. Well, it could be. It's not going to be common. Mirtazapine, this was a dirty study we did. Kids were on lots of other drugs, but it was like, well, what should we try now? And it, it was helpful for a third of them. Pretty refractory group for anxiety. Social impairment. Well, we know nothing works. There's no drug that works for social impairment consistently. There have been a lot of hopes. You've got almost every neurochemical system here. Fenfluramine causes a big release of serotonin. It doesn't do it. Naltrexone blocks opioid. Lamotrigine turns down glutamate. Amantadine affects dopamine, etc. Secondary improvement in social behavior from reducing other symptoms, sure. I'm talking about pure social impairment, nothing else. Give them a drug, nothing works. Which again, think about this a little more, because I said it today and it's sticking in my head. Why is it that none of the core symptoms that define autism get better with the drug? And when you look at DSM, most of the other ones, the symptoms that you need to meet criteria, get better with the treatment. That's pretty damn interesting. I'm just kind of coming with it right now. That's how it happens. Just like Neil Young, like the muse. I'm with the muse. It's just coming, baby, but it's true. So isn't that interesting, though? That we're all locked in on it, but nothing, it doesn't get better. So is it a disease? Are they symptoms, or what is it then if they're not symptoms that get better with treatment, right? Yeah.
Well, I think it's cognitive impairments and cognitive beliefs and the way that they function in society. You can't fix that with a pill.
It could be. It could be that, this thing got going so early in brain development. It's kind of where you're at. Stay with me.
Like concrete beliefs
Concrete.
start when they're young.
Or in early. Something happens, genetics.
Fear of dogs, fear of the bus, fear of something traumatic happened.
Well, wait, now I can't go that far. Let me back you up a little bit. Let's go this way. We'll make it pre-birth, all right? Brain development and early continued brain development. It got wired different. And they function, but it works in a very different way. They have different needs, environmental needs to remain calm. They learn in different ways. They're kind of like a different type of a human in a way. And the way they present isn't a symptom that you want to get rid of. It's just a different way of being. I mean, that's kind of what you're saying.
Yeah, processing information, all of that stuff.
Yeah.
Brain
So, I mean, that makes sense as well. That if these things are closer to what your personality's like, if you will, than a symptom, you're not going to change that. And maybe we've been hung up too much on pathologizing instead of accepting. I don't know, something like that, right? You know, I mean, big picture. So there you go. But that kind of makes you either say, it depends how you view it. Is that bad then we can never have? Or is it like, no, what's bad about it? It's just another way of being. So I kind of have to where you have to go, I think. So that's interesting. She helped out a lot. I guess I'm done, though. I can retire. And just you know what I mean?
I think you can help with the anxiety and all. The medication can help you come to a more functional level.
Yeah.
To deal with your beliefs and to
Yeah.
change how you think and interact with the world.
Yeah.
If you're higher functioning.
Yeah, their comorbidities can be interfering. We don't want to change who they are, just their comorbidities. That's a nice way to think about it. This is one that I thought was interesting. So D-cycloserine is an antibiotic used to treat tuberculosis. It's in the market, seromycin. And one of the things we've kind of looked for clues is when the schizophrenia guys do studies of negative symptoms, we kind of we watch that. It's interesting. And drugs like D-cycloserine, drugs that affect the glutamate system, maybe help a little bit with negative symptoms. Who knows, maybe. So we looked at D-cycloserine by itself in little kids with social impairment. And there was no drug placebo difference during the 8 weeks. But if you responded to drug, we kept it going, just to see. And for, I think, 4 months, 4 more months. And nobody, if it was a placebo response to drug, usually you revert back to baseline, but they didn't. They continued to maintain their response or show improvement in the social measure. So it made us wonder what that was all about, if duration of treatment meant anything. So it wasn't striking, but it might be a little bit of a clue to something. So that's Mass General. It's a pretty cool place, 1811. It's like real doctors. They put clinical care ahead of everything, which is really nice. But if you got other stuff to do, but your patient, you take care of the patient, And our team what's so neat about the Lurie Center is we have every discipline. Everything you'd want is there. So we can assess the patient from all different directions and really give them everything under one roof. They're not driving all around. And they get it from birth to death. There's no age that you come and you stay forever. All right? So you can see people change over time. It's pretty cool, the natural history of the disorder. That's my email. I get a lot of email. I don't know how many, 250 a day, maybe. So yours won't get in the way. If you want to email me, say hello, let's talk about the Beatles. What was John Lennon's first wife's maiden name? Whatever. I like that. I knew Calbert Cheney. Okay. You know what I mean? So, or questions about cases. We're not supposed to respond like it's a real case. So I'll say things like, let's pretend it's a theoretical case, and then be able to answer it. But people do that a lot when I talk. I got one guy that emails me forever from Manhattan, Hey, it's John, Okay, John, what's up? If something comes up, I don't mind trying to be helpful. I'm a nice person. Don't talk to me when I leave the stage. I have no interest in talking to you. Huh? Thank you. Thanks a lot. Oh, good. Okay. There's an art to this too. You don't want to read every question that comes up. I'll tell you that. You want to sort them out. You can get into trouble. I'll just read it. I'll read it to you. ASD became a catch-all and non-specific big something. Would you, while acknowledging all the difficulties, still attempt some meaningful classification of what this bag contains, preferentially with respect to underlying neurobiological? Yeah. So when was it? For about 5 years ago, I was in my early 50s. I have to tell the story. And I was the chairman of the Department of Psychiatry at Indiana University. I'm from Indiana. I'd gone back there. I was the head of everything, adult, child. It's the largest medical school in America. It's a big place. I had season tickets to my basketball. My parents lived there. I'm an only child, all of that. But I was bored out of my mind. I couldn't get it any better than I'd gotten it in 15 years, because you can't recruit there from this coast. You see, you can't recruit talent, and it's all about that. So I said, well, I'm leaving, I'm leaving. You got it made, man. I go, I don't feel any stress. They're like, what's wrong with that? I'm like, no, I need challenge. So I'm leaving. I'm going to Yale. I'm going to Hopkins or Harvard, whatever. I got them all. I pick your drug. And I'm not cocky. I'm just telling you the way it is. And I'm not sure why I'm telling you all that, but oh yeah, I remember. So why did I leave? Because I wanted to do more than psychopharm. I wanted to try to get into etiology, and you can't get into etiology unless you have the people around you that can do it, and the tools. And Mass General has the people and the tools. So when you go there, you say, well, pick whoever asked the question, where are you? Because I could see you, sort of. Good, hi, I like her. Is she your wife or your daughter? I think you're his granddaughter.
How'd you guess?
See? So look though, if you go, it's like Steve Jobs, you can't do everything. So you gotta pick a subtype that you think you could crack before you're done, and you pursue it. So here's the subtype, meaning pathophysiology, etiology, immune related. This is where it's gonna be, okay? I'm very good at Gestalt, pick it and get it. So here it is. There's going to be a subtype of autism that comes out of a dense family history of autoimmunity. If you have kids, I guarantee you, half of the people in the room with kids with autism, there's autoimmune disorders in your family that you know about, many of them the mother. So the more dense it is, and if it's on both sides, if the mother had it herself, MS, rheumatoid, whatever, way up. Now there's another whole subgroup that has none of that. Well, what do you expect in this mess? But there's a meaningful subtype. And so what happens is, back to you a little, well, here's a mother that doesn't have an autoimmune disorder yet, but a lot of them don't have their onset until you're in your 30s or 40s. But she's pregnant, and she has a genetic vulnerability to an autoimmune disorder. Pregnancy is a stressor. Half the baby is you. Autoimmune is attacking yourself. So you can imagine something getting screwed up there where you have an immune response, it crosses the blood-brain barrier and affects the brain development. That's not far out to me. The baby's born. Maybe the baby that wasn't born yet to have autism, but vulnerable. Well, are there any immune insults that could occur early in life? Potentially. Second hit, boom, all right? So, and then is it a process that fades off, or does it last forever? We don't know. So here, we're doing this study. So a guy gave me $5 million. He goes, here, do your best. And because we're gonna need more than that. But, so here's the theory. Families with dense autoimmunity, and a mother or father, let's say they both have it, it's a double, the baby's brain is affected during development from antibody attack or set up for an immune insult early in life. And he has immune-related ASD. Well, how are you going to prove that? Well, let's look at their brain, all right? So we have a machine, a combined PET scan MRI. There aren't many in the world. The MRI looks at structure. There's nothing wrong with their structure because it isn't fine enough to see it. Their brains look like your brain, structurally. PET scan is chemistry. It's what's alive. And you can look at these brain cells called microglia. Microglia are like phagocytes, if you will. They're like things that go after bad stuff, like immune. And if they're activated, that equals immune activation, inflammation. So let's study them, man. So we're doing, you can only do adults with its radiation, 18 to 40 adults, classic autism, versus normal control males, and compare inflammation. Where is the inflammation? It's in the areas of the brain that we think are involved in autism. Is it everybody? No. Well, does it match up with family history? We're not breaking the blind yet. We're going to run it all through. What else are you doing? Well, you draw blood and look at genetics for immune pathways. You draw blood and look at immune markers. Well, what if, can you treat it then? Because aren't a lot of autoimmune disorders, inflammation, you can treat it. You can't cure it, but you feel a hell of a lot better if you have MS and you treat it with a steroid, or juvenile rheumatoid arthritis, shut down the pain and then put them on a maintenance treatment. So that's kind of where we're going. But the point of that is you gotta pick one. And based on experience and common sense and people around you, and then go full speed ahead. Because think about it, if there's anything to it, now you're set up to do something. You can identify a vulnerable mother. So women, when you're 35, your risk for Down syndrome goes like that. You can have babies, but you go into it informed. You know, maybe one day you have an autoimmune score density of this, or you have it yourself with the density, here's your risk. Okay, great, but can we do something? Can we block a response? Can we give the child after birth something to block the response, et cetera? You can begin to approach it rather than the nonsense we do now with ASD. Okay, you got nothing. You don't have anything to grab. And genetics is, I don't know what they said in the other talks, but I just tell you what I think, you know, genetics isn't going to get us anywhere too fast. You're chipping away at it, and in the end, it's going to be good. We're all dead by then. I'm not just joking. You talk to parents like this, if you were parents, they don't care about that 100 years, that we know 3 more genetic types. What about while my kid's alive? All right, so that's what we're trying to do. Now, the other cool part, listen to this. So let's get an animal model of this, because you can do things you can't do in humans, and they don't live as long, so you can turn it over. All right, take adult female mice, and they become pregnant. These are just normal mice. Let's create an inflammatory state in the pregnant mother. Well, how are you going to do that? Do what, you know, pick it. Viral mimic, a synthetic virus, inject it. And the mother develops inflammation, which is kind of the model I'm proposing. The baby's born, baby mice, and then what are you going to do? Well, let's see what they look like compared to babies born to mothers that got placebo. What do the babies do behaviorally? Oh, they don't communicate compared to their communication is ramped down. Well, how do you know? Can you hear them? Well, we use a thing that picks up the sound of bat sounds, and it's way down. They don't interact socially like the placebo-controlled group. And they bury marbles to test of repetitive behavior at a crazy rate. So they've got the core symptoms of ASD. I'm not saying they have autism. I'm saying they have, just telling you what I see. Then you say, okay, that's interesting. And other groups have shown that, but we go beyond that. Let's look at their brain. So the connections between the cortex and the amygdala are really screwed up. Let's look at what genes are activated in the brains of the baby mice that got born to the inflamed mothers. The genes that control your immune system are off the chart, activated, like 1,000-fold. I mean, these guys I work with are real scientists. You know what I'm saying? I mean, smart dudes, and they can't believe it. They're like, oh my God. So it's really exciting when you truly get clinical and preclinical people together. Now, here's where I helped out. Every one of the babies they're showing, they're all males. I said, well, where's the females data? Oh, we throw them out. You know, don't you know in behavioral animal research you only study the males? Well, I don't know that. I said, well, you better damn get them out. Because now, look, whopping differences between males and females. The females have no response like the males. Something different like I'm in ASD. So, but now you can start doing studies of, you kind of understand this cycle in the mice. Now you can test your drugs at critical developmental time points, see what does what. So I just wrote a grant that was the biggest grant I've written in my life. I was in hell, but I want to get it. But we want to use ibuprofen, we want to use prednisone, and we want to use methotrexate in the mouse model. Because those are all drugs that are anti-inflammatory that are used in humans to treat inflammatory conditions. So the relevance of it. What does what to what and at what developmental time point? And when are there bad things that happen and good things that happen? So I think you can tell there that we we're going for a subtype that we think is real, that exists, that's still very complicated, but we can maybe get somewhere with regard to some treatments and some identifying subtypes. You know, if you say, let's get the PET scan, and if there's this much inflammation, you've got this type of autism, and it can improve with this type of treatment, things like that. So that to me is really exciting. You know, I couldn't do that in Indiana. They're fine. They just can't do that. They drink lemonade. You know, it's okay. I mean, Boston is the greatest city in the world if you like to get excited. You can see me. I don't know if I entered another zone, but I can get really, I'm very quiet. I'm an introvert, but around certain topics, I can really get excited. But very little gets me excited in life, which is why I had to leave Indiana or I would have died. No, I'm serious. I had to, somebody need to raise the bar again. But guess what? I'll meet it. You know, I'm ready to go. But that's pretty cool. If you give me your email, I'll email you a paper that describes that whole deal in great detail that I think you'd enjoy. Will you email me? You're from Ottawa. With who? Which one of those people was from Ottawa? Alanis Morissette. Can you get her autograph for me?
Okay, so I think with Dr. McDougall's expertise, like, we would like to have him forever, like, you know. But unfortunately, every nice thing has to end. So, yep, it has been really, really, you know, it's our pleasure to have you here. And then he presented the evidence, clearly highlighting what doesn't work and what works to some extent. With this, we come to the end of our conference. We hope that you all find this helpful. And so this is Friday afternoon, so